Ladies and gentlemen, first I would like to say that I am grateful to George Athanasopoulos for inviting me to participate at this meeting, and this time I could not make it to come to Athens, but I do hope that it will be an opportunity to join you personally in the future. At the beginning, I would like to recall for you a 20-year-old statement by Jos Roland, the pioneer of echoscopy, who pointed that clinical impact of any imaging technique is dependent on how and when it is used. And please note that the scope is on how, when, and what, but not on who is performing the exam. It is true that there is no substitute for sound clinical judgment. However, in cardiovascular emergencies, diagnostic capacity of clinical assessment and physical examination alone is not sufficient to safely guide patient management. And in complex clinical situations, such as cardiovascular emergencies, there are many possible combinations of causes and presentations, and ultrasound imaging of the heart may provide clue for correct diagnosis. Urgent cardiac ultrasound examination is required typically in stressful environments for critically ill patients with time-constrained, very often poor images. Critical decisions should be made, and medical errors are always the threat. And it would be interesting to know what majority of cardiologists would choose in this situation besides blood pressure, cardiac ultrasound, or any of these. So whenever I asked the audience, the answer was cardiac ultrasound for reason. There are a number of names in use for these examinations related to different type and content of the examination. And this may become a source of confusion. Comprehensive echocardiography, emergency echocardiography, goal-oriented, focused cardiac ultrasound, limited echo, handheld ultrasound exam, echoscopy. I would like to illustrate this with the case of a lady presented in our emergency department after successful CPR done in the ambulance, and she was in shock, and ultrasound examination of the heart revealed huge echo-dense space around the heart, suggesting hematopericardium. And on the left side, you can see from subcostal view, there is an obvious compression of the right ventricle with almost obliterated right ventricular cavity. And on the right side, there is a dilated non-collapsal inferior vena cava indicated cardiac tamponade physiology. Patient underwent emergent surgery and survived. And you probably agree that the case looks simple and straightforward. The question is, how would you name this examination? Or even better, is it really important how we name this examination if it may save the life? Now, please take a look at this case of the patient with chest pain, normal troponin, and normal ECG. There was no visible whole motion abnormality at the time of presentation in the emergency department out of chest pain. And however, complex analysis of segmental myocardial deformation revealed regional differences in myocardial contraction pattern, indicating possible coronary artery disease. And as opposed to previous case, this examination appears more complex, technically demanding, and requires highly specific knowledge and training. A coronary angio was done and shows severe left main disease. Thus, I would like to give you a few hints on why it may be important how we made the ultrasound examination of the heart in order to save many lives. This is an outline of what I would like to address today. And first, about the importance of correct terminology. This has been discussed in detail in 3 recent EACVI papers, one on emergency echo, one on focus viewpoint and focus core syllabus and curriculum. And seems important to recognize these three distinctive types of ultrasound examination of the heart in cardiovascular emergencies. Emergency echocardiography, which is comprehensive standard echo, full study of heart morphology and function using all echocardiographic modalities, with fully equipped echocardiography machine and performed by fully trained echocardiographer or cardiologist or no cardiologist. Focused cardiac ultrasound is a point of care cardiac ultrasound examination performed according to a standardized but restricted scanning as an extension of the clinical examination, and current evidence supports that operators do not need always to be fully trained in comprehensive echocardiography in order to obtain crucial diagnostic information, but they must be trained in focus, and handheld ultrasound devices are often used. Generally only 2D echo is used. And finally, goal-oriented echo, which is targeted examination to solve specific, often critical or complex clinical dilemmas using all needed modalities, echo modalities, and performed by fully trained echocardiographer. In contrast with comprehensive echo, there is a restricted protocol for focus with only 5 standard views for focus examination: 2 parastenal, long axis and short axis, 2 subcostal, inferior vena cava view and 4-chamber view, and 1 apical 4-chamber view. And these are generally recognized targets for focused cardiac ultrasound. Thus, anything else but a simple detection of abnormally enlarged cardiac chambers, signs of severe left and right ventricular dysfunction, large pericardial effusion, or extremely altered intravascular volumes, gross valvular abnormalities, so large intracardiac masses, should not be the part of the focus exam. One could argue that few images cannot be enough for making diagnosis. But we all know that picture may worth more than 1,000 words, and may, especially in cardiac emergencies, direct patient management as well as optimal, often life-saving therapy. For example, inotropes for biventricular dysfunction, pericardiocentesis for tamponade, reperfusion for massive pulmonary embolism, and fluids for hypovolemia. Thus, focus can change the management, and in pre-hospital resuscitation setting of cardiac arrest or shock patients actively undergoing CPR, findings from focus such as tamponade, left ventricular dysfunction, right ventricular dilation, hypovolemia, which is performed both as a part of CPR or part of the management of the peri-resuscitation state. These findings lead to change in therapy in a large proportion of patients, and also change in the choice of destination hospital in a significant number of patients, which might be very important. There are 2 important points related to focus. The scope of focus is not to completely evaluate cardiac morphology and function, but to rapidly detect limited number of critical cardiac conditions requiring urgent medical attention. And now we come to the second point, that both cardiologists and non-cardiologists can perform either echocardiography or focus, depending on clinical circumstances, equipment used, or their expertise or competence. Crucial difference is not in operator's profile, but in the amount of obtained information. Focus is usually a quick exam, lasting a minute or a couple of minutes, and not all brief and not comprehensive ultrasound examination should be considered as focus. In this case, the main question is functioning of prostatic aortic valve in patient in cardiogenic shock, and this is not and should never be the case of focus. On the other hand, at this moment, we need to urgently assess only prosthetic valve function, not completely evaluate cardiac function and morphology. But to answer this specific question, we need specific knowledge of fully trained, experienced echocardiographer who can detect high gradients across the prosthetic aortic valve by Doppler, indicating valve obstruction. This is typical goal-oriented echocardiography, and valve obstruction is confirmed by fluoroscopy that you can see both artificial leaflets looked immobile, and at this point, fibrinolytic therapy was administered. So when we ask ourselves why the names are important, terminology is important to understand and respect differences, to maintain the quality of information obtained by both full echo and focus using various ultrasound devices, and to define specific education and training for all. Important changes occurred in ultrasound imaging of the heart in cardiovascular emergencies. And nowadays, cardiologists are not only medical professionals dealing with cardiac patients, and in different situations and settings, these patients are diagnosed or treated also by emergency physicians, anesthesiologists, intensivists, fellows, GPs, sonographers, and others. So there are two general trends nowadays: progressive miniaturization of ultrasound devices from big stationary machines through mobile equipment with wheels and portable handheld ultrasound devices, and progressive expansion of users among non-cardiologists. Today, you can simply connect ultrasound probe with a cable or even wireless to the smartphone or smartphone-like device to enter entirely new world of ultrasound used by a wide range of operators outside the echo lab for multi-organ point of care ultrasound examinations assessing not only heart, but also other body structures, abdominal, gynecological, urological, blood vessels, etc. But although they all look cute and fancy, they are far from perfect. And there are a couple of important limitations of handheld ultrasound devices as compared to high-end machines. You can note relatively poor left ventricular endocardial with handheld ultrasound device as compared to high-end scanner. And a wide image sector of high-end echo scanners allows us to encompass the entire heart in the apical four-chamber view, in contrast to a narrower image sector of pocket-size imaging device. And finally, the fact that images are displayed on a small screen carries its own inherent limitations. Now we came to one important dilemma. Since cardiologists are traditionally in charge for cardiac imaging, especially for echocardiography, which is an important part of their educational curriculum, the key question for them, for their professional pride and for their professional organizations, including European Association of Cardiovascular Imaging, is would it be good, right, wise, safe to agree to support and to allow non-cardiologists not fully trained in echocardiography using handheld ultrasound devices to perform ultrasound examination of the heart in cardiovascular emergencies? You can say yes for at least two good reasons. They may save lives, and we cannot stop anybody doing ultrasound, but also what we can do is to try to make them better. On the other hand, you can say no, because some catastrophic errors may and certainly will occur, but still we cannot stop them doing ultrasound. And what we should do for the benefit of patients, we should join them in efforts to improve their skills. And one of the world's most prominent promoters of focus, Dr. Kirk Spencer, in his last review paper, on a focus for Czech cardiovascular imaging submitted before his accidental and absurdly unfortunate death, claimed for support of cardiologists to our non-cardiology colleagues to enable and help them to use focus in clinical practice. Ideally, this ultrasound examination should always be performed by an experienced acute intensive care practitioner, appropriately trained both in echocardiography and in acute intensive cardiovascular care, using fully equipped echo machine. But it is not reality. It seems reasonable to suggest that compromises have to be made due to lack of availability of specialized cardiologists at all places and locations where the critically ill cardiac patients are diagnosed and treated. In reality, we do not always need all information we can get by comprehensive echocardiography. In cardiovascular emergencies, the key issue is the level of information needed for actual decision-making, which could be tricky to judge. And there are a couple of issues that should be kept in mind when performing cardiac ultrasound in emergency setting. First, currently there is a trend to perform focus during initial evaluation in cardiac emergencies, not comprehensive effort. This trend has crucial practical consequences, since focus as a diagnostic tool is available to a big wider range of medical professionals dealing with cardiovascular emergencies as opposed to echocardiography. Importantly, echocardiography should be strongly considered following focus or after initial stabilization whenever information is sufficient for direct patient management. Anyway, we need accurate diagnostics to treat patients, and in clinical practice, there are different ways to reach the true information. I will give you an example. This was COVID-19 patients on day one at the hospital 7 days after the onset of symptoms with acute dyspnea, hypoxemia, hypertension, sinus tachycardia, and an unremarkable chest X-ray. Look at the time. Focus showed dilated right ventricle, underfilled and D-shaped left ventricle, and worm-like mass in dilated right heart consistent with thrombus. If you get key information in 1 minute by focus, it must be used for guiding patient management. And frankly speaking, in this situation, who needs all these data that can be obtained by comprehensive echo? Also, doing CT or T would be just wasting the time, and the information would be essentially the same. Does the patient receive thrombolysis? Right heart masses disappeared. You could see it on the right side, and he was doing fine and survived. The other side of the truth is that it might be complex. Good example is right heart dilation in the emergency department, which is often a puzzle, and one should be aware that clear distinction between a couple of life-threatening conditions could be hardly done solely on the basis of the cardiac ultrasound images. And we need to be cautious even in situations that looks quite clear and simple. This man presented in the emergency room with severe dyspnea, tachypnea, hypertension, high D-dimer, CRP, and leukocyte count. And ECG obtained in emergency room showed tachycardia with characteristics S1, Q3, T3, and right ventricular strain changes. And he brought with him his old ECG, obtained 2 weeks before for comparison. It was quite normal. Focus was performed, revealed normal left ventricular function, but dilated D-shaped right ventricle with McConnell sign. Patient was referred to full echo. Tricuspid regurgitation was detected, and with TR jet velocity between 3 and 4 meters per second, and with pulmonary artery flow profile showing shorter acceleration time and mesosystolic notching, indicating increased pulmonary artery pressure. So the clinical question is, would you start therapy for acute pulmonary embolism in these patients? Would you administer thrombolysis? So we didn't. We did also lung ultrasound and found multiple diffuse bilateral echo B-lines, lung comets indicating increased extracellular lung water, which is not characteristic for acute pulmonary embolism. Patient was finally referred to MSCT that showed normal pulmonary angiogram, so this was not a pulmonary embolism. And the diagnosis of ARDS was finally reached with combined focus followed by lung ultrasound and full echocardiography. And by the way, you can find in the literature that in up to 50% of ARDS cases can be associated with acute cor pulmonare. So I believe that from philosophical point of view, these two quotes offer the frame for the practice of focus and echocardiography in emergency cardiac care. There are many ways to reach the truth, accurate information, depending on clinical situations, circumstances, and we have to be aware that truth may be complex, and this is something which is good to be aware of in medicine in general, especially in emergency medicine. How to reach competence in cardiac ultrasound in emergencies. When you're providing emergency cardiovascular care, you're on a very slippery ground, and deadly errors are always possible. And of more than 250,000 deaths yearly due to medical errors in the United States, there are around 50% cases associated with emergencies, and 25% US malpractice are related to acute coronary syndrome. So it is essential to be competent in clinical medicine, and among the other skills, competence in ultrasound examinations of the heart in cardiovascular emergencies can make crucial difference between poor and favorable outcome. Also, it is important to be aware of our own professional limits in order to move forward safely. So that is why we should, in any emergency situation, always ask ourselves two questions. Does focus provide enough information for decision making? And am I competent to perform echocardiography? For reaching competence in emergency echocardiography, there are EICVI recommendations published 10 years ago, and to act as an independent operator in emergency echocardiography, the EICVI proposed two main requirements that must be fulfilled. The first, the competence of the operator should be at least the same as for elective cases, and for non-cardiologists, the same level of expertise is required. So thus, the requirements for the minimal number of cases are the same for general cardiologists and non-cardiologists, with additional mandatory program that include both theoretical knowledge on emergency cardiovascular disease and conditions and additional hands-on training in emergency setting. And I would point again that these are requirements for the emergency echocardiography, that's in comprehensive examination. Currently, after 10 years, the new EACVI Acute Cardiovascular Care Association clinical consensus could document on cardiac ultrasound in acute cardiovascular care settings in collaboration with the European Association of Cardiothoracic Anesthesiologists in Intensive Care, is in preparation by the group of experts in the field, scheduled to be published later this year. When we talk about education in focus, the first thing is to understand that medical emergencies are not the time to learn how to do focus. Keeping this in mind, the EICVI, together with the Acute Cardiovascular Care Association, recently provided focus e-learning course on the EIC website, and published focus core curriculum and course syllabus prepared in collaborations with relevant organizations involved in acute cardiac care, including European Society of Anesthesiology and FIFocus. And the aim was to provide key principles that would guarantee the competency focus of various medical professionals who intend to use it in their clinical practice. Thus, for all medical professionals of different profile, including cardiologists, anesthesiologists, intensivists, emergency physicians, and respective fellows, even those fully trained and EACVI certified in echocardiography who intended to use focus in their clinical practice, requirements for competency in focus are essentially the same. And there are three major components of practical training, including mastering focus technique, basic lung ultrasound, and specific training to use focus as a part of advanced cardiovascular life support algorithm. Due to inherent limitations, focus carries risks, two types of risks. Something important can be missed, not seen, and the operator may not understand what is going on due to restricted data set or complexity of the case. So, for example, in this patient, focus done in the emergency room reported no regional wall motion abnormality, but the next morning, comprehensive echo was performed by an expert echocardiography, and the examination clearly revealed thickened walls of the ascending aorta consistent with intramural hematoma type I. So the information was obviously there, but was not recognized and used by the fellow. And it should be emphasized that continuous supervision and quality control are essential for maintenance quality of the information obtained by ultrasound in the emergency setting. Also in this case, focus was done in the emergency room, and question was left ventricular function, reported excellent with dilated left atrium, but full echo performed later during the day revealed descending aortic aneurysm instead of left atrial enlargement with intramural hematoma, left atrial obliteration, which is the cause of lung congestion, and mass attached to the aortic valve, which was not noted on the focus exam. We analyzed the accuracy of cardiac ultrasound in critically ill patients in our hospital who died within 24 hours and underwent autopsy, and among 61% of them who had cardiac ultrasound done, 80% had focus predominantly in the ICU. And we found at least 2 cases in which focus findings were not accurate. One was missed aortic dissection as the cause of tamponade, and the other was right ventricular infarction misinterpreted as acute pulmonary embolism. So this limited experience reflects well the reason for current recommendations, emphasizing that the regional wall motion abnormalities and acute aortic syndrome are not evidence-based targets for focus or HOOD. They are beyond the scope of focus, and the assessment of these patients require training in echocardiography or referrals to comprehensive echo as soon as possible. What brings the future? The focus actually is already here for a wide range of medical professions, and its use will continue to expansively grow. And I think it's a good illustration that is coming in the future. The growing interest in focus among various medical professionals resulted in steady increase in the number of focus publications from 2010, and authors were predominantly emergency physicians followed by cardiologists. And also nowadays it becomes real to use machine learning and artificial intelligence algorithm to improve acquisition and the interpretation of the images, especially in less experienced hands. Artificial intelligence is proving to be really helpful. And you can see that if an image is not optimal, guidance messages shown on the screen stating how to move the probe in order to obtain correct image, and the quality method shows that it is not reached the automated capture level. And the right panel showed optimized image which was automatically captured, and it has been demonstrated excellent agreement between machines left ventricular ejection fraction from images acquired by the first-year medical students with ejection fraction calculated by the experts. And the recent clinical validation of an artificial intelligence-assisted algorithm which automatically identifies left ventricular endocardial borders and calculate left ventricular ejection fraction shows similar results of automatic ejection fraction as compared to those derived by Simpson method throughout different categories of ejection fraction, which indicate enormous practical clinical potential. So I believe that very soon every physician owns a personal ultrasound device and will perform multi-organ focus regularly as adjunct to a physical examination. Training will be incorporated into official undergraduate or residency training programs, and artificial intelligence image assistance will be used extensively more and more in image acquisition and interpretation. So what is the take-home message? I believe that teamwork is crucial, and this is an unusual teamwork circle that guarantees good patient care. It includes any trained physician performing focus, echocardiography expert available throughout 24 hours emergency echocardiography service, and interventional cardiologists or cardiac surgeons on call, and ICU, CCU doctors. And as a rule, patients should be referred for comprehensive echo whenever focus findings are insufficient for the immediate patient management. The final statement for the ACB viewpoint on focus, I believe, carries the essential message that for critically ill patients, it is not important whatever the life-saving information is acquired, whether by non-cardiologists performing focus or by expert cardiologists performing echocardiography. When this information is obtained, involved medical professionals should have necessary knowledge to understand and to obtain the obtained information entirely and to use it correctly, thoughtfully, and with care. At the end, in many situations in medicine, especially in emergency settings, nobody cares who did something if it is done properly. Thank you very much for your attention.
Μάλιστα. Πολύ ωραία. Μένουμε, φαντάζομαι, Νίκο, στην τελευταία διαφάνεια πραγματικά, η οποία είναι επαναστατική, λέγεται από καρδιολόγους, ότι και ποιος ενδιαφέρεται στο τέλος της ημέρας, το ποιος έκανε την εξέταση, αν την έχει κάνει σωστά και έχουν εξαχθεί συμπεράσματα. Το δεύτερο που βλέπω σε αυτή την παρουσίαση είναι ξεκάθαρα ότι πέρα από το ιστορικό και τη φυσική εξέταση, τα δύο βασικά εργαλεία οποιοδήποτε κλινικού γιατρού, έρχεται ολοένα και περισσότερο η τεχνολογία, η απεικόνηση και μάλιστα η γρήγορη απεικόνηση, τα handheld devices, τα οποία νομίζω ότι οι περισσότερες μεγάλες καρδιολογικές κλινικές με επίγοντα έχουν πλέον στην κατοχή τους, οι ειδικευόμενοι μας, οι ειδικευμένοι γιατροί στα επίγοντα και τα χρησιμοποιούν. Είναι το μέλλον ή μάλλον είναι το παρόν. Θυμάμαι μια ομιλία του κυρίου Νιχογιαννόπουλου πριν από πολλά χρόνια, 10-15 χρόνια, αν δεν κάνω λάθος, για αυτές τις συσκευές, ό,τι είχαν πρωτοβγεί και έλεγε ότι είναι το μέλλον. Σήμερα είναι το παρόν και ποιος ξέρει τι άλλο θα δούμε. Για την ώρα έχουμε φτάσει στο επίπεδο της ασύρματης συσκευής και διαθέτει και το δικό μας νοσοκομείο τέτοια. Νίκο, αν θα ήθελες να σχολιάσεις καθόλου, εφόσον είναι διάλεξη και δεν υπάρχουν ερωτήσεις από το κοινό, αν θα ήθελες να κάνεις έτσι μία περίληψη αυτών που ακούσαμε από τον καθηγητή σχετικά με τη χρήση ή κάποιο σχόλιο σχετικά με τη χρήση των υπερήχων στα επίγοντα.
Νομίζω από την ομιλία του κ. Νταβλούρε φάνηκε ότι έχει βαθύτατη γνώση του προβλήματος, γιατί μας έθεσε και το τι γίνεται, αλλά και ποιοι προβληματισμοί υπάρχουν. Εγώ θα στεκόμουν σε τρία σημεία. Το πρώτο που έθεσε είναι ποιος το κάνει. Άρα το ζήτημα είναι πόσο πρέπει να είναι εκπαιδευμένος και ανοίγει μια μεγάλη κουβέντα, τι εκπαίδευση πρέπει να λάβουν αυτοί. Σίγουρα πρέπει να είναι κάποιος expert, έχει φανεί, το έδειξε ξεκάθαρα ότι όσο πιο expert, τόσο πιο πιθανό να βρει κάτι ή να θέσει την υποψία ότι υπάρχει κάτι και σε επόμενο βήμα να το ανακαλύψει. Το δεύτερο είναι τι μηχάνημα χρησιμοποιείς. Το είπατε πολύ χαρακτηριστικά. Πλέον παντού υπάρχουν τα portable. Έχουν όμως ακόμα περιορισμούς. Μας έδειξε όμως με το artificial intelligence ότι πιθανόν αυτοί οι περιορισμοί, κάποιοι από τους περιορισμούς αυτούς, να αρθούν. Παρ' όλα αυτά γνωρίζουμε ότι τα μηχανήματα τα μικρά έχουν και συγκεκριμένες δυνατότητες και συγκεκριμένο εύρος, δηλαδή ακρίβεια στο οποίο υπάρχει. Άρα και αυτό είναι ένα θέμα με ποιο μηχάνημα κάνεις, πού το κάνεις. Απ' την άλλη, βέβαια, δεν μπορείς κάθε φορά να έχεις το σκοτεινό ήσυχο δωμάτιο του υπερήχου για έναν ασθενή που είναι αιμοδυναμικά σταθεί στη μονάδα για να τον εξετάσεις. Άρα και εκεί υπάρχει ένας προβληματισμός. Και το τρίτο, βέβαια, είναι πόσο εκτεταμένη μελέτη θα κάνεις, γιατί είπε σε μια διαφάνεια πολύ χαρακτηριστικά. Η πληροφορία είναι εκεί. Αν δεν την είδες ή δεν την ερμήνευσες σωστά, νομίζω εγώ θα πρόσθετα ότι προκύπτει και ιατρονομικό πρόβλημα. Γιατί αν ήταν ένας ασθενής που εμείς απλώς με μια υποψηφοειδική θέλαμε να δούμε ένα υγρό και τελικά είχε κάτι άλλο και ένα διαχωρισμό και δεν το είδαμε, εμείς το χάσαμε.
Είναι σωστό.
Νομίζω ότι αυτοί είναι προβληματισμοί. Δεν μπορούμε να πούμε κάποιες απαντήσεις σαφείς, αλλά σίγουρα το μέλλον έχει έρθει και πρέπει να το κοιτάμε και άμεσα, δηλαδή να προσαρμοστούμε σε αυτό.
Και πρέπει να κάνουμε προγράμματα και να το δει αυτό και η Ελληνική Καρδιολογική Εταιρεία και η ομάδα της απεικόνησης, να γίνουν προγράμματα εκπαίδευσης, τα οποία ενδεχομένως κάποια στιγμή, αν συμφωνήσουν οι περισσότεροι, να περιλαμβάνουν και γιατρούς άλλων ειδικοτήτων, οι οποίοι ενδεχομένως θα θέλουν να παρακολουθήσουν αυτά τα προγράμματα και να πάρουν κάποιο τύπου πιστοποίηση τουλάχιστον για τα επίγοντα. Έχοντας πει αυτά, να ευχαριστήσω τον Συμπρόεδρο, να ευχαριστήσω την Οργανωτική Επιτροπή αυτού του πολύ όμορφου συνεδρίου για την τιμητική πρόσκληση που μας έκανε να προεδρεύσουμε στην ομιλία του καθηγητού και να δώσω το λόγο στο επόμενο Προεδρείο, στην κυρία Νάκα και τον κύριο Παρασκευαΐδη.